Hi, how are you? My name is Nasib Balut. I'm an orthodontist from Mexico City, and it's a great pleasure to be speaking to my friends in Russia. And so it's a great pleasure to be with you that far. 2 3 years ago, I was planning to be lecturing in Russia, but because the pandemia, everything was canceled. So I hope in the near future I can be with you. Okay, so let's start. These 2 hours, I will be speaking of the treatment of class 3 treatments with the Damon system. In the early stages in growing patients and in adult patients. So, my learning objectives of this lecture is that we will try to identify the key factors, how to diagnose a class 3. We will learn the treatment alternatives of class 3 according to the age of the patient. Also, which is very important, we will learn the selection of torque with the Damon system using the variables of torque in class 3 patients. I will show you the arch sequencing and biomechanics in class 3 patients. Also, we'll see the treatment mechanics step by step in a camouflage adult class 3 patient. And we will finish with an orthodontic surgery patient treated with surgery first and a Damon system. So I hope you enjoy this lecture. So let's start. Every treatment, it doesn't matter if it's class 2, class 3, class 1, the key is the diagnosis. There is no magic, there is no intelligent system that will do the things by itself. So, always the diagnosis is going to be a key factor in an ortho treatment to get good results. Biomechanics is going to be the second situation and the technique. So I'm a Damon user for the last 23, 24 years, and I find a lot of advantage on this system. Also, we have to identify if the class 3 it's skeletal or dental, and also at which age we are treating our patients. So let's start with growing patients. What we will try to do in generally, obviously, every patient is different, but in growing patient, after we identify if the class 3 is dental or skeletal, let's start with dental. Always we have to check out in a class 3 patient if there is no discrepancy between CO or CR. So sometimes the class 3 patient, bite a little bit forward to have a better occlusion. That's a pseudo class 3. Those are the easiest patients to treat. So, first of all, we have to check, we have to manipulate if there is no discrepancy between CO and CR. We want to correct the anterior crossbite, of course. How we will do it? We might be able to use class 3 elastics. We might be using protrusion arches in the maxilla, or even inclined planes to help to procline the upper anteriors. What will we do if the problem is skeletal? Again, first of all, we have to check if it's a discrepancy between centric occlusion or centric relation, and we will try to do some orthopedics like a face mask, and we will be using differential growth of the maxilla or the mandible. It will depend how severe. In most of these patients, I like to expand and use a face mask before I start with fixed appliances. Second, once I have the proper diagnosis and I'm going to start using my Damon system, I will do my torque selection in class 3 when I'm not doing extractions, which it will be very rare that in a growing patient I will try to do extractions. So I will recommend you to have this article, which I wrote in 2020, 2 years ago. And this article is translated into Russian by Ormco Russia. You can get it from them. And there I explain what I recommend of torque selection depending on the type of malocclusion. Again, this is not a recipe, but in generally, those are my suggestions, what we will do in order to select the torque. Variables of torque are an excellent advantage that will help us in treating our patients. So usually we use class 3 mechanics. For example, if I'm planning to use class 3 elastics, what will happen with the biomechanics that I will be using? It will be the tendency that I will be proclining the upper anteriors and retroclining the lower anteriors. But I don't like to procline that much the upper anteriors, because then I will end up with a non-smile aesthetics. The more we procline the upper anteriors, the more we flatten the smile arc. And this doesn't look nice. So my recommendation for torque selection is always choose low torque brackets on the upper 4 incisors, and depending on the inclination of the lower incisors, I will be using low torque or standard brackets because the mechanics. I will talk a little bit more when I will be talking about the biomechanics I'm using on class 3 patients. So this table, you will find it in the article. What will be the torques that I will suggest in a class 3 non-extractions? I like to place high torque upper and lower cuspids. Why? Because I want to keep the roots center in the basal bone. I like to place low torque brackets in the upper and lower incisors. In a surgical case, and there are no high torque lower incisor brackets. So I like to place standard torque brackets, and I will add positive torque. But this is just in surgical cases. If the lower incisor is very retroclined, that sometimes is commonly seen in class 3 patients, then I won't put low torque brackets. I will place standard torque brackets. In extraction cases, class 3 extraction cases, sometimes to camouflage the case, we extract upper second bicuspids, lower first bicuspids. Obviously, I do this extremely rare, and I will do it just in non-growing patients. So I will be using a high torque in the upper anteriors. On the lower anteriors, upper laterals, I'll always like to place low torque brackets because I don't want to end up with a procline laterals. Remember that laterals are very difficult teeth to control torque because they are in between two big ones, the cuspid and the central. So a lot of times at the end of the treatment, we end up with laterals slightly proclined. So that's why always I like to place low torque on upper laterals. And in lower incisors, I might place, there are no high torque for lower laterals. I will place low torque brackets, but upside down, or standard torque brackets. So in generally, this is my selection of torque that I will use in all my class 3 cases. So the earlier that I can treat a patient, the better. Look at this case. This patient, it's about 6-7 years old. And if you see his profile after year and a half of treatment with fixed appliance, look at the changes that we gain on this patient. It looks like we use a face mask. We didn't. Obviously, with fixed appliances, I'm not doing an orthopedic change. I'm just changing the position of the upper and lower incisors, and also I'm changing the direction of growth. Here, this patient has a very horizontal direction of growth. Here, we change a bit, making the patient a little bit more vertical and changing the position of the upper incisors. And look at the changes that we will end up with fixed appliance. Again, I'm not expecting an orthopedic changes with fixed appliance, but we can help a lot our patients. So that's why I'm saying in a class 3, the earlier, the better. This is the same patient. You will see the overbite to begin with is in a crossbite, anterior crossbite. Usually we have retrocline the upper incisors. At the beginning of the treatment, because I'm using round wires, I will procline the upper anteriors. But as soon as I can place a rectangular arch wire and having low torque brackets, then I will not end up with a proclined upper incisors. So I'm taking care of the class 3, but also I'm taking care of the aesthetics of the smile. So this is very important. And this is why variables of torque, they play a very important factor in our mechanics with the Damon system. So why we do early treatment and what is the best age to start? As I say, in class 3 patients, the earlier, the better. So we can diagnose earlier at class 3. Of course, there is not enough evidence to point towards early or late treatment. But in my 35 years of orthodontic experience, I have been having very good results treating patients at early stages. Why? We have an increased cellular activity, so it will be easier to treat the patients. And I think we must help patients with concern and consideration of their self-esteem at early stages. Plus, we want to have a more efficient practice in our offices. Early treatments with proven benefits. We can easily correct posterior dental and anterior crossbites. This is the same patient. It looks like I place a screw to get this arch development, but with the cellular activity that we have at these stages, look at the arch development that we can have on those patients. Obviously, diagnosis, it will be very important, and I'm using a lot the CBCT to find out if we need to expand orthopedically with the screw or with the MARPE, or we can do it just with the arch wire. In this case, we did it just with the arch wire. So these are one of the most benefit things in early treatments with class 3. What are the possible treatments that we usually do in class 3 patients? Most of them, we have to do some arch development or use some removable expansor. I don't like to use them that much. I would rather to use something fixed. We can use fixed appliance like a quad helix, W arch, or Damon brackets. If the problem is dental, if we don't have a skeletal problem, that's what I like to use. I look to do also rapid palatal expansion, either with a MARPE or with a Hyrax when I have a skeletal transverse problem. And most of class 3 patients, we will need to do some time of either arch development or expansion. And we will find this through our diagnosis. Another proven benefit of the early treatment, not just in class 3 patients, is that we can have a lot of arch length discrepancies. So we can even gain more than 8 millimeters. Again, because the cellular activity, we increase the vertical overbite. We can even help in protrusive patients with their lips and profile. And here we can see an example of a severe crowding patient at early stages, what we can gain. I even use the deciduous teeth. If you can see, I place eyelets, so that will help me to get the arch development. In when we have a lot of crowding, I place lotor brackets, so that will help me to avoid the pro-inclination of lower anteriors. Look at this patient. He's not a pseudo class 3. He doesn't have a CO-CR discrepancy, but if we treat them at the early stages, look at the changes that we can have in the profile. Of course, there is no orthopedic change. The patient still class 3, but is growing in a better direction. We cannot yell victory in these cases. The victory, we will get it until the patient finish their growth. But I think we can help them a lot. Look how we change the direction of growth. We change the inclination of the upper and lower anteriors, and we can have a lot of changes on the profile of the patient. So I think there are a lot of benefits when we treat our patients at these stages. So the CBCT, they are gonna help us a lot in the arch development of our patient. Look at this case. This case was treated we start treating the patient in 2013. Of course, we have them in 3 different stages that I will talk, the different phases. And here's when I'm finishing the case. That doesn't mean that I will have the patients with fixed appliance for 4 years. I usually have them 1 year, 1.5 years. I got the arch development. I got the leveling align. I can be using class 3 or class 2 elastics. And then I let the patient rest without the fixed appliance. I will wait for the option of the bicuspids and bicuspids, and then I will bond again, and we will end up with this, with very nice changes. I think something wrong happened. The presentation went out. I'm gonna put it back. I'm sorry for this inconvenient, but we are again. I hope that everybody is seeing. There are a lot of concerns when we place brackets, fixed appliance on developing maxillary incisors. The concern is about the root apex. And this is a myth. There are a lot now of scientific evidence, but I will show you there was no significant difference in the total length and root length of maxillary and lateral central incisors when we place brackets. We are not going to stop the root development with the fixed appliance. I'm going to show you some cases. Look at this case with the apex totally open. we place them on brackets and look at the root development. It's completely normal. Here we'll see the differences. Another case with an impacted central. Look at the apex of the other central incisors. They are completely open, and this is after a few 2 years of treatment, how the development of the roots are completely normal. Here is the differences. So we don't have to be worried about placing fixed appliance like diamond brackets on incisor upper and lowers that they have the root open. So what are my protocols that I follow in my patients at early stages? Obviously, class 2 or class 3 patients. We will see now one class 3 patient treated at early stages. But the best stage to start the treatment is when we have erupted the upper and lower first molars, and when we have the upper 4 anteriors and lower 4 incisors. This is the best stage to start an early treatment. So this will be another topic. I cannot spend that much time talking about my protocols of early treatment. But I place diamond brackets between 12 to 18 months to have everything level and aligned, to have the arch development, and I might be using class 3 or class 2 elastics. Once I get these objectives, I remove the brackets. This is the phase 2. I place fixed retainers over the upper 4 incisor and lower 4 incisors, and I will keep the patient just in observation between 1 or 2 years, waiting for the eruption of the bicuspids and cuspids. And phase 3, I will rebond the diamond brackets, remove the retainers, level and align again. I might be using class 2 or class 3 elastics, and will be a much easier treatment. Usually it lasts between 8 or 14 months. Those are my protocols that I use in early fixed appliance with diamond in growing patients. So let's see now an early treatment of a class 3 patient with diamond system. So we will see the photos of this patient. This patient is about 8 years old. And here we can see the crossbite, the class 3 tendency, the crowding, the frenum very low. This patient, he doesn't have a transversal discrepancy. He mainly has the class 3 tendency and some type of crowding. It is his lateral ceph, where we can see the class 3, where we can see the point A and point B. The inclination of the lower incisor with the mandibular plane angle is pretty good. The upper incisor is a bit proclined. So I'm going to choose low torque brackets. As you can see, even the upper incisors, they are not erupted yet. First, the patient doesn't have enough space. Those laterals are stuck. So we are going to create space over those teeth. Here we can see the panoramic X-ray, and you can see how open are the roots of the upper incisors. As I said before, we can diagnose this case. It's not a severe class 3. He has the tendency. There is no discrepancy between CO and CR. As we can see in the CBCT that we took on the patient, when we see a discrepancy between CO, CR in maximum intercuspidization, we won't see the condyles in the right position. So that's why I'm saying this is very important that clinically we check if there is no discrepancy between CO, CR. Obviously, it's going to be easier to treat our patients when they have this discrepancy, because it won't be a real class 3. So here is the patient, about 10, 12 months with fixed appliances. We were creating space for the laterals. We were using class 3 elastics. We choose low torque brackets on those centrals. Sometimes we place a very light open coil to make space for those laterals. But the problem with the open coil is we might procline more those upper anteriors. So I won't place the open coil until I have at least an 18 by 25 copper night tie arch wire. And since the first appointment, we are using class 3 elastic. Light class 3 elastics, about 2.5 ounces. And this is gonna help us a lot. We are getting the arch development, and we are helping with the anterior-posterior horizontal growth. This patient didn't have a transversal discrepancy, so we will get rid of the crowding very easily. What is the choice to place an eyelet on the deciduous teeth? Not to align the teeth, is to help me to have the arch development. I place the eyelets if at least I have 2/3 of the roots of these deciduous teeth. If I have less than the 2/3, then I won't place nothing, because I will accelerate the exfoliation of this tooth. So here is the patient. As you can see, the root continue develop normally. I like to overcorrect. As you can see now, probably I have more pro-inclination of the upper anteriors, but I'm increasing the overjet of the patient. So I will continue using the class 3. And as I said at the beginning in my protocols, during the phase 1 on early treatment, usually it lasts between 14 to 18 months. So once I get aligned all the teeth, as you can see, now we have the laterals erupted. We have a nice arch transversally, upper and lower. We overcorrect slightly the class 3. I have a positive overjet now. So I'm ready to debone the patient and place fixed retainers in the upper four incisors and the lower four incisors. And then I will pass to the phase 2 of the early treatment that I will keep in observation with my patient. The patient, it's better. I change a little bit the direction of growth. So now I remove and I will keep the patient in observation. This is at the end. I didn't have the photos, but I place the brackets again to finishing, leveling, and align. So here are the final photos. No, I'm sorry. This is when I was ready to place the brackets again, just to finishing, leveling, and align. As you can see, I have the lower fixed retainer in the lower four incisors. The upper retainer fall down. So now my treatment is very easily to finishing him. Here are their photos, the profiles. Those are the sequence of the mechanics that we use. And let's see the patients. 2 years after we debond. Yes, probably he's still having some straight profile. As I said at the beginning, we cannot yell victory until the patient finish his complete growth. Now the patient is about 15, 16 years old. And here are the lateral cephs in different stages of the treatment. So in generally, this is what I do in growing patients. It will depend the severity of the class 3. It will depend if we need to expand just with the dental arches, or I might need a fixed screw. I love to use Marpe appliances even in a growing patient. So now let's start with seeing different patients that finish growing. We will see 2 cases. Then I'll show you one case, how we treat her step by step. But let's start seeing this patient. She had an ortho treatment in the past. She had a slightly class 3. She's edge to edge. I don't like her profile. She has a slightly class 3 tendency with a vertical growth. In those patients, even is not that severe, but I think a class 3 woman, her profile doesn't look that nice. And as you can see, the midline is shifted to the right. You can see it also in her profile. So these cases, my main option treatment is it's a surgical case. And yes, probably a lot of you will say, no, this is not surgical, it's too much. But I think those female patients, we will change a lot the profile. So the patient, when I proposed her to do the combined ortho surgical treatment, she said, no, I'm afraid of surgery. I just want to change my bite. That's what she said. I like my face and I don't want it to change. So we decided to camouflage it. How we can camouflage these cases? I like to be very conservative in the beginning. I'm always try to solve the case with class 3 elastics to begin with. If the patient don't use the elastics or if they don't work as I was expecting, then I will use mini implants. In this case, one mini implant on the left side to improve the class 3. So here is she. We can see that she's a class 3 with some vertical growth. Her bite, her occlusion on the incisors is edge to edge. She doesn't have the third molars. As I said before, she had an ortho treatment in the past. She had some growth and relapse. Here are her CVCTs. We love to take in all my patients CVCTs. Now I'm not using even the lateral ceph or panoramic X-ray. I take the CVCT. If I need to do some tracings, I can get the lateral ceph from the CVCT. Also, I can get the panoramic view from the CVCT. A lot of people is concerned taking a CVCT mainly for two reasons. The first one is the amount of radiation. And now it's enough scientific evidence to say that is not be much more radiation more than a lateral and panoramic X-ray. And secondly, a lot of people is saying that they don't send the CVCTs because the cost. And I will add another third reason. The lack of knowledge how to use the viewers on the CVCT. So for me now it's very important to take a CVCT at the beginning of the treatment to do the diagnosis and in the final stages. So what we want to evaluate, obviously the anterior posterior discrepancies, the sagittal view, the axial view, and the coronal view are going to be very important to help me evaluate the cortical bone. And there is no way I can evaluate cortical bone other if I don't have a CVCT. Also, after we evaluate the patients clinically, evaluate the TMJ, evaluate the relation that the condyle has in the glenoid fossa, the shape of the condyles, and the shape never is equal the right and the left side, and also evaluate the airway. Those probably are the main reason. Probably we will be another ones, but today I will speak about those. The cortical bone is going to be very important in a non-growing patient. If I want to have some arch development, we have to evaluate the cortical bone, mainly in those patients with a very thin biotype, periodontal biotype. Also, we evaluate the amount of inserted gingiva in order to decide if I want to have that arch development just with the fixed appliance, or I might need another type of appliance. Also, cortical bone will be very important when I'm using low torque brackets. The amount of cortical bone that we have is very thin. Usually, it's sometimes even less than half a millimeter. And if I place low torque uh, inclination of these patients, I might I might end up with the apex out of the cortical bone. And clinically, a lot of times we don't even note it. So I don't want to do blind orthodontics. That's why I think this is very important. So let's continue with the patients. We can see that the length of the corpus of this patient is longer on the left than the right side. There is no problem on the TMJ. There are no symptoms. Obviously, there are no discrepancy between CO, CR, that it might be very commonly in this type of asymmetries. As you can see, the position of the condyles in this case. So we start the treatment. Now I will show in one patient step by step what are the mechanics that I'm using. Usually I start with light wires and class 3 elastics, light class 3 elastics since the beginning. Unfortunately, the patient was not very good with the elastics, so we weren't seeing changes in the left side with the class 3. So we decided to put a mini implant in the shelf, in the mandibular shelf, to help me distalize the lower left quadrant of the patient. Also, the CBCT is going to help me to see the amount of distalization that I can get. And we measure from the distal root of the second molar to the lingual cortical bone of the mandible. This is the amount that we can distalize. In this patient, we don't need to distalize that much. So if I gain 2.5 millimeters of distalization of the lower third quadrant, it will be more than enough. So why we choose this area to put the mini implants is because the oblique line start getting thicker, mainly between the first and second molar. So that's the place I like to place the mini implants. Usually we use 12 millimeters long mini implants in that area to get the distalization. So as you can see, this is the CBCT. This is the area of between the first and second molar. So we place the mini implant almost parallel to the first and second molar in this area to get the distalization of the lower quadrant. So we use a 12 millimeter longs vector TAS mini implant. We will try it to place it between the first and second molar. This is the lateral view of this patient. This is her mandible taken from the CBCT, and this is in anterior posterior view where we place the mini implant to distalize the quadrant. So this is the way she was with the class 3 relationship on her left side with the mean line off. We need some arch development in the upper arch. She had some perio problems, so we control the periodontal problem before we start the treatment. So now we can see the distalization, the light distalization on the left quadrant. We have the light class 2. Now we are overcorrecting. And once we get the distalization, I place a fixed ligature wire to the first bicuspid to continue with my mechanics once we get the distalization. Now we don't have the edge to edge relationship. We got some distalization, and this is her at the end of the treatment. Now with a better overbite and overjet. This is the way she was at the beginning, and we camouflage the problem because she was not very used with the use of class 3 elastics on the left sides. We need to use a mini implants. So we distalize the lower left quadrant that help us to correct the midline and improve the overbite and overjet in these patients. We can see the arch development that we have in the upper arch. We level and align and distalize the lower left quadrant to camouflage the asymmetry, the skeletal asymmetry that she has on her mandible. We can see the improvement on the overbite and overjet at the end of the treatment. So again, we always need a proper diagnosis. I said it at the beginning, there is no magic. There is no the intelligent technique or arch wire that will do the things by itself. So again, in a no-growing patient, we have to identify if the skeletal or dental class 3 can be solved with a camouflage, trying to move dentally and correct dentally, or we need a combined treatment, orthodontic and surgery, orthodontic surgery. Also, it will depend a lot of the age of the patient. If we have a young adult or we have a more older patient. So again, it's very important that we identify if we don't have a discrepancy between centric occlusion or centric relation. This is very important. So what will be our diagnosis and treatment planning in non-growing patients? We have to identify if the class 3 is dental or skeletal. If it's dental, again, we have to check if there is no COCR discrepancy. Then we will camouflage it. How we will camouflage the problem? I always will try to start with class 3 elastics since the beginning. You will see now a patient that I just treated a severe class 3, just with class 3 elastics. We might think of the distalization of the lower arch, helping with auxiliary techniques like mini implants, or sometimes we will have to think in extraction. I don't like never just extract the lower first bicuspids because I will never get a good occlusion on the posterior teeth. So if I try the class 3 elastic, if I try the distalization and it didn't work out, then I will decide for the extractions. I will extract the upper second bicuspids and the first bicuspids and will control my biomechanics. A lot of people think that Damon user never do extractions. Of course not. There are some cases that we need to do extraction, not because the amount of crowding. Sometimes we need to extract because the profile or class 3 patients. So if we have a skeletal class 3, first of all, I will check if there is no discrepancy between CO and CR. It will depend of the severity of the skeletal class 3 that I will decide my treatment. I might be able to camouflage even when it's a severe class 3, again, with class 3, with distalization or extractions, on or all of them. Or sometimes I will need to do an orthodontic surgery, usually class 3 surgical cases, I will do it always with surgery first. I will finish my lecture with one surgery first case treated with Damon system and surgery first. So let's see this case. This is a patient with a severe class 3, as you can see. Obviously, in these cases, my first choice always will be surgery. Why? Because I think we will have a much better change in the profile of the patient. But sometimes the patients, they can afford it, or they are afraid of the surgery, or like the parents of this patient, they said, doctor, please try just to do it without surgery. There are some cases, the class 3 is that severe that there is not even choice to try to camouflage. In this case, I told the patient, okay, we will try it. There is no transverse problem, which is commonly seen in class 3 patients. He is in a full class 3, both sides, and look at the negative overjet. And unfortunately, he doesn't have a CO-CR discrepancy. In these cases, I wish that they have this discrepancy, because sometimes they bite, and in order to have a maximum intercuspidization, they move forward, and they have this CO-CR discrepancy. This patient didn't have it. So I told him, okay, we will start with the Damon system. We will use class 3 elastics that you have to wear them full time. Sometimes I even tell the patient, because I'm using light, short class 3 at the beginning, 2 ounces, that they even can eat with them. It's very light force. They don't feel it. But this is one of the great advantage of the Damon system, that we have low friction and we can use low forces. And this is a big difference that we can get. As you can see, the patient has a class 3 situation. It's a class 3 due to the growth, more growth of the mandible. Look, where is the point A and where is the point B? That's why I'm saying, ideally, this is a surgical case. When I start the patient has around 16, 17 years old. He has all the permanent dentition. He didn't want surgery. The inclination of the lower incisor is not that bad. It's not that retrocline. The upper incisor is already a bit proclined. So what will be my torque selection in this case? I will be using low torque on the upper 4 anteriors, on the upper 4 incisors, low torque on the lower 4 incisors, and high torque on the upper 4 cuspids. Look, there is no CO-CR discrepancy. His TMJ is in a perfect situation. No symptoms. The shape and the relation between the glenoid fossa and the condyle is good, is perfect. Watch out with using heavy class 3 elastics, because sometimes we force the mandible, we force the TMJ. I'm not concerned forcing the TMJ with light class 3 elastics. So what are the options that I have with this patient? Let's go back. I can start the treatment with intermaxillary class 3 elastics, light. If they don't work, I might be using a mini implant in the mandibular shelf, trying to distalize the whole lower dentition. And the last situation that I might be using is extracting the upper second bicuspids and lower first bicuspid. This will be my last option. We also have to look for the smile, the aesthetic of the smile height, the vocal corridors. And in this case, I would love to intrude the lower anteriors. That intrusion, I will be helping by bracket positioning. By the way, Ormco Russia has my article published in the JCO about the strategies for smile aesthetics with bracket positioning. It's also translated to Russian. So I'll recommend it to you to get it. So I would like to intrude the lower incisors. Usually class 3 patients, when they smile, they show more the lower anteriors. So I would love to extrude the upper anteriors to camouflage this class 3 patient. So let's see what we did in this case. So now, let's see what is my art sequence in a class 3 non-extraction cases that I use most of the times. This is very important. Usually I start with 014 copper night eye, upper and lower. Usually I leave the wires not all the way to the second molars, just to the first molars, the wire, even though I have the tubes for the sevens. This is just to avoid emergencies, because usually the wire came out very easily from the second molars. So I leave these arch wires between 3 to 4 months. And since the first appointment with these arch wires, I use class 3 elastics, light class 3 short elastics. Why I'm saying short? Because I'm using the elastic from the upper first molars to the lower first bicuspid. 2 ounces short class 3 elastics, and the patient use those elastics full time. They can even eat with them. And if they cannot eat them, I just told them, just take them out to eat. But usually they can even eat with them. So I used short class 3 elastics, 2 ounces, 3/16. Then I will move on to a 14x25 copper night eye, upper and lower. This is my friendly arch. This is the arch that I will get the arch development. Sometimes I need much arch development, that I will do it with stainless steel arch wires. And I would leave these arch wires at least for 6 months. And obviously they goes all the way to the second molars, upper and lowers. I will continue with the class 3. Sometimes I increase the force, and they are not going to be short class 3 elastics. Now the patient will be using the elastics from the lower cuspids to the upper molars. They are 3/16, 3 ounces. Then I will move on to an 18x25 copper night eye arch wire. This is just my transition arch wire, and I will leave this arch wire between 1 or 2 months. I'm saying it is my transition arch wire because then I can use a TMA or stainless steel arch wire. Another thing very important is at this stage, at the final stages of my 14x25, I check my bracket positioning. I change to have my root parallelism, to have level and align my marginal ridges, and also I check for my smile height and smile arc. This is very important. I never move to a heavier wire if I don't have very good bracket positioning. I will continue with my class 3 elastics. Now I use a little bit heavier elastics, 4 ounces, 3/16, from the upper first molars to the lower cuspids. Then I will move on to an 18 by 25 TMA in the upper arch and a 17 by 25 stainless steel or TMA. It will depend when I'm using a stainless steel, when I need more arch development, and if the cortical bone allow me to do that. If I don't want to have that much arch development and I want to have much or control my torque, I use TMA. Why I don't finish on a 19 by 25 in the lower arch? Because I always want to have less friction, and usually the torque requirements are more in the upper anteriors. So that's why I use a 19 by 25 in the upper arch and a 17 by 25 in the lower arch. So this is generally my arch sequence in my class 3 patients non-extractions. It will vary the amount of time that I leave the arches. For example, if I have a lot of crowding, then I will leave the O1 for much more time. If we are using the smart arch, then I will start with 016, that again, I leave it for 2 to 4 months. We'll do the same. Load short class 3 elastics, 3/16 to ounces. Then I will move on to 18 by 25. Obviously, it's the smart arch. Remember, the smart arch have a different force in the anterior area than in the posterior area, so we can use less arch wires. So this is gonna be, in the smart arch, will be my friendly arch. I will be using heavy wire, and I will finish my case with the same arch wires. So it will, these are my 2 arch sequence arch wires that I will be using in class 3 patients non-extractions. This is the arch sequence with the smart arch. So let's see the patient. I'm gonna show you just the finished one. You will see another case step by step. This patient was very cooperative. So we never need to use mini implants. Just with class 3 elastic, bracket positioning, changing my bracket positioning before I get to the heavier wires, we were able to solve the full class 3 in both sides. We were able to intrude the lower anteriors. Because the low torque that we were using, I didn't end up with a big pro-inclination of the upper incisors. I'm concerned about the smile aesthetics, as you will see now. Look at him at the end of the treatment. He didn't have that transverse discrepancy. So in this case, I didn't want to have a lot of arch development. I was able to extrude the upper anteriors to improve the smile arc and the smile height. And also we intrude the over extrusion that the patient had on the lower anteriors. And this is the profile. I don't love his profile. As I said at the beginning, I would rather treat this patient surgical, but it's not bad. Obviously, we improve a lot, but I think his profile is very Max. But he's very happy. And again, he didn't want the surgery. And let's see the CVCTs at the initial and final. As you can see, I didn't finish with a big pro-inclination compromising the cortical bone. We didn't retrocline that much the lower anterior, so we didn't compromise neither the cortical bone. And here is the TMJ at the beginning and at the end. We keep the relation. The patient didn't have any symptoms at the beginning, so we keep the relation. And before I debone, and always check the excursional movements at the protrusive and lateral movements, because a lot of times it's mistake, errors on bracket positioning that is giving us these interferences. And this is the smile arc and the smile hat that we end up at the end of the treatment. So now let's see this case step by steps, the way we manage a camouflage case with the Damon system. We have to do, first of all, again, and I have to repeat it, do our diagnosis with the CVCT. Now I don't take the lateral ceph and pano. I'll do my diagnosis with the CVCT. And photographs will be very important to evaluate the macro, mini, and micro aesthetics that was suggested by Dr. David Sarver. So I want to end up the case with a good dental and skeletal relationship. With the macro aesthetic is going to help me if I want to extrude more the upper anteriors, to evaluate my vocal corridors, and evaluate my smile arc. So it has to do a lot with bracket positioning, and also is going to help me for the torque I'm going to be using and the mechanics that I'm going to using. Same thing, I will do it with the photo for the mini aesthetic and also for the micro aesthetic. If I want to end up with a nice smile aesthetic, we have to consider the gingival contour, the size, shape, and tooth, and even the color. Sometimes we have to reveal the incisal edges once we level and align to improve bracket positioning and improve the smile aesthetics. So let's start evaluating the case. I'm going to do my diagnosis with the CVCT, focusing on the aesthetics. I'm going to do my torque selection according to the mechanics, the biomechanics that I'm going to be using, and also according to the cortical bone that I will see in the CVCT. Then I will check for my bracket positioning based on the smile height, smile arc, and facial aesthetics. Again, I will recommend you, I don't have a photo of it, but the article about bracket positioning and smile aesthetic, we published this article with David Sarver, and Ormco Russia translate these two articles to Russian. So if you contact Ormco Russia, I'm sure they will be more than happy to give you the articles in Russian. And then we are be able to start the case with efficiency and always thinking and having the case with the end in mind. And it has to be a lot of bracket positioning. By the way, I said that diagnosis is one of the main things to have a nice case. The second most important thing is bracket positioning. And if you want to end up with a nice results, you have to be aware that you have to be changing bracket positioning during the treatment before you get to heavier wires. So what are the consideration or the factor to consider in torque selection? There are 4. Periodontal biotype. If I have a thin periodontal biotype, or a patient that had in the past periodontal problem, watch out with low torque brackets. Avoid to use them. I would rather to use standard brackets because the cortical bone. We have to evaluate what is the initial tooth inclination, evaluate my mechanics. I told you class 3 mechanics always will have the tendency to procline the upper anteriors and to retrocline the upper anteriors. So we have to think in the torque selection that we'll be using to avoid sometimes the collateral effects that will have on torque these biomechanics. And the 4th is what is the final tooth inclination that I want to finish. Let's see why it's very important. And we evaluate tooth by tooth the amount of cortical bone that we have in order to use the torque. Here is the upper lateral incisor. We have, sometimes it's very difficult to see the amount of bone, but we can see the thin layer that we have on laterals. So we have to be careful on not to add a lot of low torque in this case, because for sure I will end up with the apex out of the cortical bone. And clinically, I won't see it. The central, we have a very nice cortical bone. We can be using the low torque brackets. We can see the class 3, the anterior negative crossbite that we have at the level of the lateral left incisors and on the central. So watch out with our mechanics. This is very important for the torque selection. I show you this table. We can use low torque brackets. This is a young patient, is around between 22, 24 years old. The amount of cortical bone is very good. Just in one incisor is not good. You will see it because the position of the incisor. We have to take care about the cortical bone in this one, because it's behind and the root, it's a little bit over the root of the lateral. Sometimes the amount of cortical bone on those cases is not as nice as we would like to see it. So when the good thing is when we are leveling and align, we will bring the crown forward. The root will stay back. we have to add the low torque. Even though we have low torque brackets, in these cases, we have to add the low torque. So watch out with the amount of low torque that we're gonna add. That's why it's very important that in the final stages of the treatment, we take another CBCT to evaluate our cortical bone before we debone the patient. So look at the inclination that we have on these cuspids. So we want to end up with these cuspids with the roots center in the basal bone. So we will be using high torque brackets. Red, that means that it's our high torque brackets. In the upper anteriors, I want to use low torque because I don't want to procline them that much. And for sure, I will need to add more low torque to this tooth. Just watch out of the amount of torque that we will be adding. Look at the inclination that we have of the lower cuspids. Are like they have the tendency to be lingually positioning. So again, I want to have the roots center on the basal bone. So I will place positive or high torque brackets. On my lower anteriors, they are not that retroclined. So I will be using low torque brackets. And we have to look for the bicuspids. They are lingually positioning too. So I might not have the variables of torque in the anteriors, but I might need to add torque on the arch wire to those teeth. So I put like if there were high torque brackets. They are not, but I'm gonna add torque to these lower bicuspids. So let's see the case and let's start evaluating the macro aesthetics. Again, this is a girl, it's a female with a class 3 tendency. I always, even is not that severe, I'll have the tendency to treat them with surgically. Obviously, she's not unhappy with her face. I proposed it, and she said, no, I don't want surgery. I just wanted to have my teeth straight. So if we see her smile on the macro aesthetic, usually a class 3 patient show more lower incisors. So I have to take care of my bracket positioning to extrude the upper incisors. Probably I'm not gonna be able to improve that much, that profile, but it's not bad. Let's see her occlusion. She is in a class 3, almost full class 3 on the right side, as well as the left side. She has the slight negative overjet in the anterior area. And again, I want to look at the position of this lateral. It's behind the upper incisor. So the cortical bone on this tooth is not gonna be as I wish, even though the patient is young. I want to improve the smile arc. Look, the height of one cuspid is a little bit down than the other one. So I want to improve the smile arc. I want to have more arch development that I can do it because it's a young patient. And I want to extrude the upper anteriors. We can see her lateral ceph. The inclination of the lower incisor is pretty good with the mandibular plane angle. The upper incisor is already slightly proclined. She has a negative A and B. The point A is back from the point B. It's a mesocephalic type of patient with a good inclination of the lower incisor. Is 96 instead of 90. And the upper incisor is slightly proclined. That's why we have a decreased interincisal angle. The third molars are present. There is no perio problem. So if I see the third molars in a good position, for me there is no need to extract them. So we evaluate the cortical bone. She has a very nice cortical bone just here in this lateral, because it's behind the central, the cortical bone is not that nice. She has a prognatic profile. She doesn't care about the profile. So what are the treatment options in this girl? Ideally for me, it's surgically, but she doesn't want surgery. Again, I want to be very conservative, and I will start the case with class 3 elastics. If they don't work, then I move on to use stats in the mandibular shelf. And if nothing of this works, then I will decide to do extractions, upper 5, lower 4s. I don't like to do that much this, but it will be, this is my last option. This is my ideal option. So I have these two to treat this case. So let's see what are the heights of the brackets that I decided to use to extrude them. Look, I place the brackets on the centrals at 5.5, lateral 5, cuspids 4.5, and then I will place them the back posterior segments 1.5 more occlusally. So read the articles, you will see. My bracket position is related a lot with the macroaesthetics. So let's see what we did step by step with this case, with this diagram. So we start with Damon Q brackets from second molar to second molar, upper and lower. We place biturbos. In all of my cases, I place the biturbos because they allow me to have a better arch development. I have the disocclusion, so they help me to keep my TMJ relationship, and also helps me that the patient don't break, don't take off brackets because the eight hard things, mainly in growing patients. I will start with an 014 copper night eye from first molar to first molar. No, I don't place the 014 all the way to the second molars. This is just to avoid emergencies. I'll continue to the 7s if I have a very bad rotation of is not in a very good position, then I will continue the arch wire to the second molars. But as you can see, the second molars are not bad here, upper and lower. So at the beginning, to avoid emergencies, I leave in upper and lower just to the first molars. And I will leave these arch wires for, as an average, for between 3-4 months. If I have a lot of crowding, then I leave them for more time. And I will start using short class 3 elastics, 3/16 from the first bicuspid to the first molar. Both sides, full time. I even recommend them to use them while they're eating. If you feel the pressure of these elastics, they don't feel. So usually they can even eat with them. So they are using them full time. I place a very light open coil. Even the length of the open coil is probably half of the width of a bracket. It's just less than a millimeter to start opening up the space in that area. So you will see in blue are the months, and in blacks are the weeks. So I left the upper 14 copper night tie almost 4 months, the lower 3 months, the short class 3 elastics 4 months, and then I moved with the same force but large from cuspid to the molars. The turbos, I left them almost for a year, and the open coil, I left them less than 3 months to open up the space. So here you can see the case. The patient was very good wearing her rubber bands. She had them full time. So look at the spaces that we open up, and these spaces were not because I have a pro-inclination of the lower anteriors. First, she didn't have crowding. This is slight distalization of the lower quadrants. Look at the turbos. With the open coil, we made space. We start leveling and align. And look in the lower arch. So at the beginning, with the round wires, with the open coils, what is going to happen? Because I'm using a round wire, the tooth will be proclined and the bite will open a bit. I'm not worried about this. I will solve it with the rectangular arch wires. And look what is happening with the lower third molars. Because I don't have brackets on those, and the force which is distalizing, look the thickness of the ligament, periodontal ligament of the cuspids is getting thicker. I'm distalizing very little, probably it's about millimeter or so. But the force, the third molar that is not having a bracket and is against the ramus, what is going to happen to those? They tend to extrude because the elastics and the force, the third molars are extruding. So I was not planning to extract them, but since they may cause some interferences, then I decided to extract them. So then I move on to a 14/25 copper night tie, open and lower all the way to the second molars. I left them as an average for months. We are at the 7th month of the treatment. We continue with the turbos, and also we continue with the class 3 elastics. Now I increase the force of the elastics, and now they are from the cuspid to the upper molars. And I want to overcorrect. As you see in the panoramic, the third molars are extruding. So I don't want to have interferences. Because we have some spaces that were created, I decide to place a elastic CK chain, a chain from molar to molar to close the spaces. Then I move on to an 18 by 25 copper nitride, upper and lower, and continue with my class 3 elastics. So now I am over correcting. Remember, I had a almost full class 3 molar and cuspid, and now I'm in purpose provoking a light class 2 in both sides. I want to overcorrect the case, continue with the class 3 elastics, and I have now a class 2 relationship. I don't want to have a big arch development. I just want to reduce the vocal corridors. And because now I'm using a rectangular arch wires, look how I'm recovering the overbite and overjet that we created at the beginning. She take a little bit long to extract those third molars, but look how they are more extrude. They are not causing yet any interference. I need more root parallelism in this lateral and this bicuspid. What I want to see is enough amount of bone between roots to have a periodontal stability. So I insist on her to extract the third molars, and we need some root parallelism. So I change. Before we get to heavy wire, we always need to change the position of the brackets. So here again, before I move on to 18 by 25, I take another panel, I take a lateral ceph to check the torque, and with the photo, with the digital photo, I will evaluate my smile and bracket positioning. That's the appointment that we call it, as Dr. Stuart Frost says, the pano repo, but it's not just the pano, it's the lateral and photos that we take before we get to the 18 by 25. Look at her smile now. When she smiles, she shows much more the upper anteriors. The profile is still the same. And we compare. Probably in this photo is smiling more than in the beginning. And this is normal. When the patient has crowding, you force them to smile. While we keep them straight, they have more confidence, and now they show more the teeth. This is normal. Here we see how we, with the round wires, we might procline and open up the bite, while we place the rectangular arch wires, we control the bite. So we need to improve the smile arc. We need to extrude more those laterals. That's a mistake that I had since the beginning. That's why I recommend to use a star to measure the position of the brackets. I recontour the incisal edges to have a better position. And as you can see, I move up those brackets. We are, at this time, we move on. Once we have good bracket positioning, we move to an 18 by 25 stainless steel arch wire in the upper arch and a 17 by 25 stainless steel arch wire. We have the midline a little bit off, so that's why I use asymmetrical arch wire, intermaxillary elastics. Watch out with this. Try, if you need to use a symmetrical intermaxillary elastic, like in this case, class 3 in one side, class 2 in the other way, do it with heavy wires. Otherwise, you might end up with the tilt of the occlusal plane. So as you can see, we need to correct now for the midline. That's why we were using. We have now a better smile arc, but we need to check out for the gingival contour also to improve the smile of the aesthetic. So we did laser to improve the size of the clinical crowns. This is after a week. They look better. Because the use of elastics, we create a small space. We place a chain in the lower arch with the 17 by 25. And we took the CBCT before we debond to check the torques and the cortical bone. We need to change more one position of the brackets. When we're almost ready, we send the patient to the periodontist to improve the gingival contour. And here is she at the end of the treatment, the way we correct the class 3 on the right side, the class 3 on the left, the amount of arch development in the upper and lower arch, and how we improve the overbite and overjet. Here is the superimposition, the digital superimposition at the end of the treatment, and look at her smile when we debond. And the changes on her profile that were very light, but we have a big improvement in the smile on the patient at the end of the treatment. Okay, so let's go to see our last case. It's a class 3 treated with surgery first and Damon system. This patient was sent by the oral surgeon. This patient didn't like her profile. She asked for the surgery. So let's see her occlusion. Can we treat this patient camouflage with brackets? Yes, we can do it like the other patient. She's a female. My first choice is surgical, but I didn't need to convince this patient because she already was convinced. She didn't like her profile, and the patient was sent by the oral surgeon. And we are going to treat this patient with surgery first. She has some type of crowding in the lower arch, very light crowding in the upper. She doesn't have the third molars extracted. And here we can see the class 3. We took the CBCT. We did the predictions, and we decide in this patient not doing a mandibular setback. Here are the predictions with the surgery. So in surgery first cases, I bond the brackets a day before the surgery. and I send the patient without wires. I will put the wires in the operating room at the end of the surgery. So they did the mandibular setback. Here, before they place the sutures, we check the occlusion. And what I want to see and what we predict is to see a slight class 2. We increase the amount of positive overjet. That is why we want to give torque to the lower anteriors. Usually, class 3 patients have retrocline incisors. So in surgery-free first cases, I want to add positive torque to this teeth. So before they place the suture, we check the position of the mandible. And in the operating room, I place the wires. I place round copper night type arch wires, as you will see now, because the amount of crowding. And I will indicate the intermaxillary elastics that we are using right after the surgery. We cannot use heavy intermaxillary elastics. So here is the patients. Now at the end of the surgery, we place the wires, it's suture, and the surgeon usually leaves with the surgical splint for 2-3 days. So here is the patient. 8 days after the surgery, we can still see in the suture, we remove the surgical splint. We had an 014 copper night tie in the lower arch and 018 copper night tie in the upper arch. This is the type of occlusion that I want to see right after the surgery. A positive overjet. So that is gonna help me to give a better root torque on the lower anteriors. This is her face 8 days after the surgery. This is 15 days after surgery. We start using some W elastics, 3.5 ounces, to help me to settle down the posterior occlusion. This is her face, 15 days after the surgery. She's still with some swallow. 5 weeks after the surgery, I'm having a 16/25 copper night tie in the upper arch, 14/25 copper night tie in the lower arch. This is her face. 10 weeks after the surgery, I am in a 18/25 upper and lower. I did these steps to include a bit the upper and lower anteriors because it was a big interference in that area. That was the reason of that steps, as you can see it here. This is her 3 months after the surgery. I have 19/25 upper and lower. In this case, I wanted a heavier wire in the lower arch because the torque of the lower anteriors. So the patient, after 3 months of the surgery, is almost ready to debond. Everything is level and aligned, upper and lower. We have a better occlusion, and this is her when we debond. Her case lasts 4.5 months. That's one of the biggest advantage of surgery first cases. We reduce the amount of treatment because we eliminate that pre-surgical orthodontic time. So this is her face at the end of the treatment, and this is her occlusion at the end of the treatment. Surgery first, diamond brackets. So it's almost 2 hours. I want to thank you for this opportunity to be talking to you in Russia. I know it's not a good time because the situation that all the people is living there. I hope we end up soon with peace. It's our desire for us. So I'm again giving you my thanks and regards to all my orthodontic friends in Russia. I hope to see you sometime in presence. And this is my email. If you have any questions, I'm open to solve the questions. I'm connected with the people through the WhatsApp. If you don't have the question now, you can send me an email and I will be more than happy to answer any question. Thank you very much. So let's see if there is any question. I'm waiting on the WhatsApp. They told me that we will wait a bit to see if there is any question. I will be more than happy to wait for it. Okay, they told me that they don't receive any questions. Anyhow, here is my mail. Anything I can do, I will be more than happy. So again, thank you very much. And thank you to having me through online. And thank you for all the people that is back here to helping having this virtual conference. Thank you very much and take care. Bye-bye.